So welcome everyone back after our long summer break, and we are now on chapter 23 of the Bouncebacks Critical Care book. This is Emergency Medicine's first and only monthly book club, and we have 30 chapters total. When we embarked on this odyssey back in 2021, I had never thought that it would go on for 4 years. I guess I could have done the math. So thank you everyone for devoting an hour of your time tonight to us. We hope to be true to that. And most importantly, hope to improve patient care in the process. The case we're going to talk about is a true case. And in a really cool way, we actually have the physician who cared for that patient as one of our panelists. We're going to go through the case, the initial visit briefly, but with the Bouncebacks Critical Care book of the 4 books in the series, this one really focuses on the return visit and the different decision points that we can go through. We're going to see what our panelists would recommend, what the actual clinician did, what happened to the patient, and then we're going to move to another decision point. So all of that being said, I'm going to share the screen here, and I'll tell you that we do not have anything to disclose as far as the content of the discussion tonight. Colin Kaide has a financial relationship with a company that does not have anything to do with what we're talking about. So just want to make that aware. We'll keep that up there for a second. As we talked about, everyone gets 1 hour of free CME credit. So we will have this code here. We will have the code available at the end that folks can scan that again at the end. And if anyone wants to sign up for the subsequent Bouncebacks Critical Care book clubs, you can go to just the easiest way, EM Bouncebacks. So EM, like emergency medicine, bouncebacks.com. And we'll have also QR codes for signing up and registering for additional ones towards the end. So I wanted to jump right in. We'll introduce our fantastic panel. First is Jennifer Hicks. She is a resident at Adena Medical Center where I work. And we have Colin Kaide, who folks I'm sure have heard speak on the national circuit. He is an emergency medicine physician at the Ohio State University. Steve Kornweiss, he is also an emergency physician, and he had been working in Spartanburg, South Carolina, and is actually now he told me, doing the opposite, which is trying to prevent people from going to the ER. So we won't make any jokes about that, Steve. So Mike Pallaci, good friend and a coworker I've worked with for several years, and he's now at SUMA up in Akron, but also he's professor of emergency medicine. Nicole Tyczynska, and she is associate professor of emergency medicine. And also George Willis, who you have heard, I'm sure, many times on MRAP, talking about some things near and dear to his heart, mostly endocrinologic type of things. So we're going to jump right into this case here. I told you that we were going to tell you the story about this patient, and the story is the actual documentation. So nothing has been changed. This is the documentation that actually happened, and what happened, the patient's story, is actually reflected in the information I'm about to give here. So this patient presents, as many of them do, probably the second or third most common complaint in the emergency department is abdominal pain. Came in at quarter after noon. He came from a nursing home per EMS. You can see his vital signs were pretty basic. And by the triage nurse, they said abdominal pain, possible constipation. So you might be getting a little bit of a foreshadowing as to maybe what this wasn't. The patient has a history of diabetes and dementia, so we know our history is going to be a little bit compromised. But here's the history of present illness. We're going to talk about that in just a second here. Epigastric pain and nausea since yesterday. Denies fever, vomiting, lower abdominal pain, dysuria. History is limited by dementia. So as I've said in the past many times, we are the historians. However, absolutely, sometimes patients are not able to give an adequate history. So on the exam, the abdominal exam, and we'll jump right to that, epigastric tenderness, no rebound or guarding, normal bowel sounds, alert and orient times 2. So we know he is able to give some bit of information. And the patient had testing, including an abdominal x-ray and some labs. And I will just tell you that all of that came back normal, except, all of that came back basically normal, except for the fact that he had tumors to count white blood cells in the urine. The abdominal x-ray showed a large stool burden, and his pain improved after a bowel movement. So the reason I really like this case is because it's the type of case, if we wouldn't know that there was some sort of bounce back visit, that all of us might have handled in the exact same way. And I think the best type of teaching case are not like the obvious cases or the esoteric cases, the ones where we say, yeah, I might have handled that in the same way. And maybe that gives us, myself included, of course, the opportunity to go from standard of care to excellence in care. Patient is diagnosed with constipation and UTI. He is sent home with a prescription for macrobid and Miralax. So why don't we start with Mike Pallaci? Because what I really am curious about, Mike, and again, we're looking back on it, and we're also, in all fairness to the actual physician at the bedside, we are talking about one patient with a physician who's probably caring for 15 people at a time, right? So give us a couple pro tips with your years of experience. When you can't get a great history from the patient, maybe there was an opportunity to get some additional information that the patient is not able to give at the bedside.
Right. I mean, history is limited by dementia helps you, but it only gets you so far, right? I mean, did you try to call the nursing home? Did you try to contact family? They came in by EMS. Did you try to talk to them? Is this their baseline dementia? Are they more confused than usual? I mean, there's a lot of things, a lot more than I'd want to know. And if he's with it enough for you to document that there's no fever, there's no vomiting, that he's had these symptoms since yesterday, that he doesn't have any dysuria, then he's probably with it enough to know, whether he's had any symptoms of GI bleeding or whether he's had any other urinary symptoms. Does the pain radiate? Other associated symptoms, chest pain, shortness of breath, fatigue, considering things in the chest like MI and pneumonia. So, while the history is limited by dementia is probably enough for billing purposes, in terms of trying to get to the bottom of the diagnosis and in terms of medical legal protection, it's probably light.
So I have to say, and you mentioned the medical legal part, and I promise everyone listening to this call, I have now done 120 medical legal cases as an expert, and it is so frequent that the thing that is lacking is the bedside data gathering, is the history. That's free information, right? We're at the bedside, we don't have to worry about risks or side effects of testing, right? We get information from talking to the patient. And again, this guy did have some limited ability to give information. So that's the history. And Mike, you talked about some other ways to get history. Now, if this patient was Little times three, we could certainly ask about acuity of onset, location, radiation, all those different things. And look, we got a person who is pretty old, 70 years old. So, all those other very bad things like AAA, et cetera, would certainly be in play. So, George, I want to bring you in here next because I want to look at this exam. And I will tell you also in my experience, and this is more just with, the residents that I work with who are documenting, that we oftentimes have this huge exam, head is normocephalic, that's awesome, right? But the really important part of the exam sometimes isn't quite as thorough as we'd like it to be. So, George, what is your thought on the abdominal exam? Maybe you think it's adequate, or maybe there are some ways that you think you could have potentially improved it.
There's a lot that's missing on this exam. One of the things that I always make sure to document on my abdominal exam specifically is, are there areas of tenderness, but also are there areas where there are no tenderness? So is there specifically any suprapubic or right lower quadrant or left lower quadrant abdominal tenderness? And if there's not any, then I actually document the absence of that tenderness, especially if I'm concerned that this person may have some kind of intra-abdominal process going on. Certainly the fact that there's no guarding or rebound is certainly important to document. However, this patient's also an elderly patient. They may not have the presence of guarding. They may not have the presence of rebound tenderness. And so I don't really 100% rely or hang my hat on that physical exam finding. Sure, documentation is extremely important. However, in this patient, it would not alleviate any fears that I potentially could be missing something in this patient. Another thing that's really missing is a good neurologic exam. And that's one of the things that I would really harp on in this, is that this patient is alert and oriented only times two, is that we know that this patient may have a history of dementia, but are there other things that may be present that could cause the clinician to miss something on this exam as well? And then one of the things I always check or at least ask about is a GU exam and then a rectal exam. Do I necessarily do a rectal exam on every single patient who comes in with abdominal pain? Absolutely not. But certainly I ask about other symptoms that may make me kind of lean towards, should I do a rectal exam in this person who I'm considering constipation? Is there a big rectal mass? Is there a big stool ball that's present? And then certainly don't want to miss anything like a Fournier's or a hernia that's present that could be causing some things like a bowel obstruction or things, something like that. So I always want to document those parts of the exam as well to make sure that we're not missing any other potential etiologies.
Yeah, I mean, even just piggybacking while you were talking, one thing I was thinking of, and it's not, incredibly sensitive, right? But things like pulsatile abdominal mass or presence of surgical scars or any bruising, all those other things. And then also, I was thinking of this too while you're talking, with the epigastric pain, maybe this is not purely a intra-abdominal process. Certainly, this could be a potential cardiac process, right? Because, epigastric area or even pancreatitis, right? Other things could potentially going on. So Jennifer Hicks, we have just a short differential on this patient, right?
Differential is pretty broad still on this patient. So some of the things that would be like emergent or life-threatening for this patient would be like a viscous perforation, an obstruction, pancreatitis, cholangitis, mesenteric ischemia, like was already mentioned, a non-GI process like an MI, a ruptured AAA, or a dissection. And then secondary differentials that are not so life-threatening would be things like PUD, GERD, a hiatal hernia, gastritis, a duodenitis, biliary colic, and constipation.
So Nicole, I sort of prompted a question that I was going to ask you, and I want to ask you that question in just a second. But, Jennifer mentioned some really bad stuff, but most of the time it's not that bad of stuff. In fact, a study by Fenmore and JAMA on patients with chest pain, only about 1 in 10 or 1 in 20 patients with chest pain will actually turn out to have ACS, and certainly less with PE. And I found a really cool study recently by an author named Alter that looked at what is the prevalence of dissection in patients with chest pain of all comers. They found 1 in 980 patients with chest pain will have an aortic dissection. So you think to yourself, that's not that common. On the other hand, if you see during the course of your career 150 to 175,000 patients, you see 15 or 20 patients with dissection, certainly missing that. Well, actually, that math wasn't perfect, right? So say 6% of our patients chest pain, so maybe you see 10,000 patients in your career. So even if you miss 10 patients during your career with dissection, of course, that's way too many. If it potentially, patients that have a potential surgically amenable, life-saving type of thing that can occur to get that better, of course. So Nicole, long question, and it can be a long answer too, but how do you balance out these potential bad things with not as bad things, also knowing that the patient got better after bowel movement, when you're deciding what testing you're going to actually do? And then I'll ask you specifically between acute abdominal series and CT scan. Nicole, I cannot hear you, although it doesn't look like you're muted.
Of our emergency department.
There we go. Would you mind starting that over, Nicole? Sorry about that.
Oh no, did you not hear me?
Yeah, no, your sound just came on. I'm sure you said something super brilliant right in the beginning there. Hope you remember it.
No, what I was saying is, so specifically with this patient, so we see a lot of abdominal pain in the emergency department, and we're not CAT scanning every single patient. So there needs to be some form of clinical pretest probability or suspicion that we have that lead us to CAT scan certain patients and not others. And specifically in this patient, there are a couple of things that make me lean towards being more conservative. Number one is the fact that this patient is elderly. And I know that that's kind of the second half of this question, but elderly patients. So there was a study that showed that about 45% of patients over the age of 65 will have some kind of surgical pathology if they're coming in with acute abdominal pain. It's a really high percentage. So just out of the gate, somebody who is over the age of 65, I'm already thinking that a CAT scan, there's a high probability I'm scanning this person. And specific to this patient, we have this history of dementia, an uncertain change in mental status. We're not sure how altered this patient is compared to normal. and maybe some uncertain recent history of presenting illness. So for this patient specifically, I would like to hang my hat and seek some more objective data. So I think uncertain history of dementia, older patient, that's going to be a CAT scan for me. Patients that can give me a more reliable repeat abdominal examination or more reliable history, then I will kind of think twice in pulling it all together with the labs, with the history and the exam.
So Colin Kaide, and we're going to, for everyone's sort of information where we're going with this, we're going to have two more questions, then we're going to get to that bounce back visit. We're going to tell you what the patient bounced back with, and then get to some of the critical care aspects of things. But just sort of wrapping all this up, Colin Kaide, your resident comes with this, chart, patient with abdominal pain, 70 years old. Do you feel like the story has been told, that the argument for why this is safe to send this patient home has been made? And feel free to say yes. Again, you don't really want to just think that something bad happened to the patient.
Well, I've also done a decent number of medical legal cases, and when an attorney comes up and says, "Hey, I've got a case," and it's an older person with a history or a story of constipation, I feel, and I'm going to age myself here, I feel like Horseshack and Welcome Back, Kotter. I'm ready to go, ooh, ooh, ooh. Was it a AAA? Was it a perforation? Was it a ischemic bowel? And as soon as I start hearing that diagnosis, it makes me a little bit concerned. It's not that it couldn't be those things, but it makes me a little bit worried when I have an older person with abdominal pain, especially if I can't get a really, really convincing history. And an interesting part of this is the confounding factor that you did have a diagnosis that wasn't unreasonable. It's not crazy to say, wow, you got too numerous to count white cells in the urine. I've got a reasonable diagnosis. The problem is that the patient's complaint of epigastric pain really doesn't exactly go along with that. And when I see that conflict of, I've got a diagnosis that's going this way, but I've got an exam that's going the other direction, I have to try to resolve those a little bit in my head. And that makes me believe an older saying that I used to have, that I haven't met an elderly abdomen that I haven't CAT scanned. And I know that's paranoid a little bit, but I don't think it's terribly unreasonable. We CAT scan a lot of people for a lot of reasons that don't make a lot of sense. I wouldn't consider it a wasted scan. Now, one other comment, and I don't want to belabor it too much, but one other comment, the differential diagnosis that was given was a good differential, but just be a little bit careful. An attorney asked me what the definition of a differential is, and I said, well, it's something that medical students spout, and it's also something that plaintiff's attorneys read off to you and asks you why you didn't prove that it isn't everything in that list. So just be cautious that sometimes differential diagnosis is an inside word, and sometimes it's a set of words that you write down, but just make sure that you write down something that's reasonable. So I think there's potential for trouble here, but overall, there was a diagnosis that was made, and it wasn't crazy, it wasn't unreasonable, it wasn't out there. I'd also be a little careful with the idea of dementia, because if I can't get a reliable history, I don't mind putting them in the donut of half truths in order to try to find out an answer.
And I'll refer folks to an episode of MCRIT that just actually came out, I believe, yesterday. And it's actually myself and Scott Weingart talking about documentation issues in a medical legal type of framework. And exactly what you're saying, Colin, that's one of those things. And very clear, missing a diagnosis is not malpractice. And from my definition, poor data gathering, poor medical decision making is malpractice. I don't think this case is malpractice in any way, shape, or form. That was just sort of an aside that I was going to say, and I say that with all due respect, because our chapter author for this chapter is actually here with us today, is Steve Kornweiss. And Steve, you actually were involved with this case. Were you the first physician, or the second physician, or the physician who saw the patient on both visits?
I was the second physician. I saw this patient on the return visit.
Okay, good. Because I have to say, honest, a little bit of a window into my soul. I started thinking about this first visit while we're talking. I'm like, oh God, I hope Steve is not just like feeling like really terrible about himself. So it's easy to, criticize when you're not there. Again, we're seeing one chart. Maybe this physician was seeing 15 people at a time. So Steve, why don't you give us, as the chapter author, some of your sort of closing thoughts as far as maybe just one or two or 3 things that could have been done to improve this patient's care?
Yeah, I mean, I think Colin really nailed it with what he just said a moment ago. And it's cases like this that really helped me to hone in on the way I started to think about diagnosis as I got further on in my emergency medicine career. And the way I started to do it was I would have two parallel differential diagnoses in my mind, kind of the way it was broken down in the chapter. One set is my emergency medicine diagnoses, which of the history, based on the history and physical and presentation, what diagnoses could be going on that are going to kill this patient or make them critically ill. And then the other differential is a little different than what's on this slide. The other differential is, what do I actually think is wrong with the patient? And what I started to do as I got a little bit better as an ER physician is something that I was not taught to do. I was always kind of taught to just rule out the worst, and I changed my strategy a bit. I had the rule out the worst differential going, but at the same time, I was trying to make a definitive diagnosis that unified the entire presentation, because that's the best way to rule out other things, is to actually make a diagnosis. And so I tried to not get stuck in the rule out mindset too much. And I think what Colin pointed out is exactly right. This patient has epigastric tenderness that doesn't fit really with constipation. Constipation can cause intermittent abdominal pain, but not typically a whole lot of tenderness, not true tenderness. And a UTI doesn't explain it either. And I think we'll get into this a little bit more in the next section of your talk. But the question of whether or not the urinalysis actually supports the diagnosis of UTI as well.
Yes, so as expected, as advertised, the patient did return to the emergency department. So I'll go briefly through the return visit, and we're going to look at our different decision points, which is our main focus of the discussion tonight. So 4 days later, the patient returns at 4:24 p.m. And as you can see, he's now tachycardic, tachypnic. He moans and grasps his abdomen, and the paramedics tell you his blood sugar prior to arrival was greater than 500. And at this point, he's not even alert and oriented ×2. Now, his initial management was with some morphine for the pain, IV fluid, Zofran. His ECG showed sinus tachycardia, so not any signs of STEMI or any type of arrhythmia. Chest x-ray was done as normal, but you can see his labs here. He had a little bit of some leukocytosis. His serum bicarb was on the lower side, certainly. Hyponatremia, beyond 38 creatinine 2.6, and that compares with normal numbers 4 days previous. Blood sugar 430. And then you can see the VBG there, 7.25, PCO2 is 20. So LFTs and lipase are both normal. So why don't we jump right in? And Nicole, I want to start with you. You know, you think of a differential for abdominal pain be quite broad. Let's move away from the abdominal pain just temporarily. How about a patient who is altered, but then you see an elevated blood sugar, or maybe even that combined with the abdominal pain? How does this narrow your differential and focus your evaluation?
So it's a little hard because altered mental status alone has such a broad differential. And the question is whether you want to keep at it broadly so that you don't miss anything and just include all the common, AEIOU tips, altered mental status differentials like your metabolic, endocrine, tox, infectious, psych, neuro, tons of that, right? Or if you want to try to find the overlap between altered mental status, hyperglycemia, and abdominal pain. When I think specifically about that region of overlap, the things that I would consider high yield as a differential from the endocrine perspective, we know they're hyperglycemic, they have abdominal pain, they're acidotic. I would be thinking about either HHS or DKA, which can cause all of those things. So that would be definitely high on my differential. We already are probably anchoring a little bit on that UTI if we've done a chart biopsy. So sepsis with worsening abdominal pain, hyperglycemia could be found in septic patients because they have this increased catecholinergic state. So they could also be altered abdominal pain and hyperglycemic. And then finally, another thing that kind of matches all of those is a possible toxicologic differential, although I would hope that if they're coming from a facility that they didn't get into anything, but something like a calcium channel blocker or a salicylate overdose can cause kind of all three of those. But truthfully, how I would go at it clinically, I would just throw a very wide net and try to encompass all of the altered mental status diagnoses, which could make somebody really acutely ill.
Excellent. And so what I want to do is ask both Colin and Mike, and we can sort of reverse order this time. So we'll go Colin first and then Mike Pallaci next. But And then we're gonna have George sort of wrap some of this together as far as if the patient actually does have DKA as the medic suggests. So, Colin, first you know, Nicole said cast a wide net. There's obviously a bunch of stuff going on. Tell us specifically what that net looks like for you, both as far as evaluation testing as well as any further management, medications, fluids, etc.
I kind of think from what I'm seeing here that I see that acetone is negative. I pulled up some of my differential diagnosis for an acidosis here, and it's going to sound like this is going to be a lactic acidosis. This guy is probably there's a good possibility he's septic. I see that the BUN and creatinine is significantly elevated. The BUN, you know, that could be pre-renal, but more likely it's digested blood. Um, you know, I'm seeing somebody who I think looks septic to me, and if I take into account the CT scan, I kind of have a pretty good idea of what's going on here, or at least some pretty good thoughts. If I was before the CT scan, my first thought would be to focus on resuscitation of this individual because this person is hypotensive, and I probably, if I was thinking of an abdominal source, I would probably have broadened out the coverage a little bit from ceftriaxone to something that's going to address interperitoneal problems, and I would focus at that point on looking again, making sure that I don't have a GI bleed from a rectal standpoint to see if I don't have gross blood. And I would be focusing on resuscitation at this point, trying to get that map up. And it's going to be fluids initially and eventually switching to pressors. Knowing the CT scan result, it helps me out a lot here.
But we don't know the CT scan result just yet.
Okay, yeah. So if I don't know, I'm looking at a patient who I presume to be septic or is having some sort of bad intra-abdominal process leading to this acidosis that I'm seeing here. It's probably going to be lactate.
Okay. Mike Pallaci, a couple thoughts?
Well, I mean, there are some ketones in the urine, and you know, I do think that DKA is definitely still in the realm of possibility here. So I agree with Colin. I would be focused on stabilization, aggressive IV fluid replacement, and then pressors if they're refractory. And as our co-panelist pointed out at ASAP in Vegas just a few weeks ago, if you have it available to you, plasmolite or lactated ringers is probably the better initial resuscitation fluid for a few different reasons. We'll skip over that in the interest of time unless George wants to cover it in a couple of minutes. The other thing that I want to do is make sure that I'm continuing to monitor their mental status. If this is DKA, or maybe even if it's not, you know, they're trying to compensate for their metabolic acidosis by hyperventilating, and you see that they've breathed their CO2 down to 20, otherwise they would be even more acidotic, and we need them to continue to do that. But so that's the reason we try to avoid intubating patients like this if we can. However, if they are continuing to vomit, and they're altered and not protecting their airway, you may have to do it. So aggressive antiemetics to try to prevent that, aggressive stabilization with IV fluids, pressors if they're refractory, preferably ringers or plasmolite, something more physiologic than saline. And just keep an eye on their mental status to make sure you don't need to intubate them for airway protection.
So we're going to bring George in, who is truly expert on diabetic ketoacidosis, DKA, and then we're going to really have a nice window into the fact that we're seeing the chart. But Steve, I'm going to bring you back in because I want you to tell us what you actually saw when you were at the bedside of the patient. And sometimes that's able to be reflected on the chart, sometimes it's not. So, George, the medic suggested that the patient had DKA. That was the chief complaint you see on the top of the chart here. Give us some wisdom. DKA, HHS, just hyperglycemia reactive to the underlying process. What do you think?
This is a really great and important point, and that is one. Not all that is hyperglycemia and acidosis is DKA. And Colin hit that nail right on the head. It's something that I see my residents do all the time. They're like, "Oh, Dr. Willis, I have a patient with DKA." And how do you know it's DKA? Well, they have an acidosis and they're hyperglycemic, and that's it. And they're missing that there's other things that are necessary. So if you look at the guidelines from 2009, which is the guidelines that have been prevalent for since that time frame, you'll find that the diagnostic criteria include the following. They need to have a glucose that's elevated greater than 250. They need to have an anion gap that's greater than 12 or 17, depending on how the lab has measured it. They need an acidosis present, and that acidosis can be present with either a pH that's less than 7.35 or a bicarb that's less than 19. And they need ketones present in the serum or in the urine. So recently, as of 2024, January, I believe, no, I'm sorry, it's June of 2024, they just updated the guidelines. And so the guidelines are different now, not significantly different, and that is to allow for the presence of some of these kind of we'll call them off-label DKAs, like the euglycemic DKAs. So now the blood glucose level has been lowered to 200, or they just need a previous diagnosis of diabetes at some point in time in their life. The anti-gap is still the same, the acidosis is still the same, and then the ketones that's present, and this is a point that I'll get into very shortly, is that the beta hydroxybutyrate has to be the ketone that's elevated, or they have to have urine ketones that's greater than 2+. So based off of the new diagnostic criteria, this patient doesn't meet criteria for DKA simply because they don't have greater than 2+ ketones. They just had a small number of ketones in the urine. And that the point there is that the ketone that's measured in the urine is actually acetoacetate, which is the least dominant ketone body that's present in presence of diabetic ketoacidosis. The most common ketone body that's made is actually beta hydroxybutyrate, which is why that level is checked. And a lot of emergency departments now, and even now, patients have access to point of care beta hydroxybutyrate levels to where they can actually test themselves to see if they're going into DKA. So relying on the urine or the absence of a urinalysis ketone is to your detriment. If you're really concerned that this patient may have DKA, getting a beta hydroxybutyrate level is going to be your most useful test. Now, the reason why EMS
Hey, can I interrupt for 1
may
second?
have...
George, I'm sort of curious because just staying on that question just real briefly, is there a number above which I think ours is like if it's above 2, that's probably standard maybe, then that's considered elevated for the beta hydroxybutyrate level. Is that right? But is that
So,
like
yes.
diagnostic if it's above 2, like something like the lipase being 3 times normal, 95% specific, or is there still some sort of room for play if it's a little bit elevated?
Well, as we all know, patients can be at the very beginning when they present to the emergency department, and so they may have levels that are 2 or 2.5, and maybe in very mild DKA. The diagnostic criteria, they use the number 3, greater than the number 3.
Okay.
But in the grand scheme of things, I still think that if a patient has an elevated beta hydroxybutyrate level, and I use the number 2 for my own purposes, then you can start thinking about that diagnosis as possible etiology for what's going on.
Nice. And I cut you off. I'm sorry. I wanted to stay on that point just for a second because I want to give some real
Sure.
specific bedside stuff.
So the only other thing that I was going to add is that I questioned why the medic got this diagnosis of potential DKA. And the only thing I could come up with is sometimes you can, and our medics here in San Antonio have this available to them. They can use an end-tidal CO2. And the end-tidal CO2 level, if it's less than 27, that can kind of sway you towards the diagnosis. If the level is higher than 27, you've essentially ruled DKA. So if you get an end-tidal CO2, that level is greater than 27, you're done. You can continue looking for other potential etiologies. But if it's less than 27 in a patient who has elevated blood sugar, again, you might think about the diagnosis of DKA, but going back to Colin's earlier point, that just means that they have an acidosis that's present. So the goal and kind of the thing that the clinician should be doing at this point in time is finding what the etiology of that acidosis is once you've discovered that the patient has an acidosis. And so in this circumstance, I would say that since we haven't fully met the criteria for DKA, we certainly should be looking for other potential etiologies, remembering mud piles for looking for other causes of an elevated anti-gap acidosis.
Awesome. So Steve Kornweiss, you actually saw this patient. We're sort of all like thinking about all this stuff, but what did you see? I mean, do you remember that patient coming into the room with the squad and what he actually looked like?
Yep. I mean, I think even though the charting here is very brief, it pretty much paints the picture. The patient was awake, restless even, so not obtunded, but disoriented. So the altered mental status is the nature of that is really disorientation, but not obtunded or depressed mental status. The working diagnosis of DKA really came from two places. It did come from the EMS squad. And if I recall, it was purely based on this high blood sugar, the sort of thing where they came in and probably said something like, oh yeah, this patient probably has DKA, and something very informal. I don't think it was a more detailed diagnosis based on an end-tidal CO2 or anything like that. And then this was my first job, and very shortly after I graduated residency, and I was already managing residents as an attending. And so the residents saw this patient primarily and came out with the working diagnosis DKA. And so that was all the stuff that I had in my mind going into the room. And when I went into the room, the patient was unable to tell me anything. And we could not get a hold of anyone at a facility who was familiar with the patient. And the family was unreachable. And eventually when they were, did not speak English, and took us quite a long time to understand what the baseline status of this patient was. And somewhere along the lines, we were also given the information that this patient had some psychiatric mental illness history as well. So the presenting history here was very minimal, and a few confounders were thrown our way in that regard.
Yeah, and that's always funny. Like, I know Colin had talked about the medical legal part. It's like, you really are just talking about one patient, and that's not how a shift goes. There's never a shift where that's the only patient in the ED, and they speak English, right? So, all right. So, what did the actual provider do in the situation? Or I should say the physician and the resident, which is a physician too, gave a couple liters bolus of fluid, morphine, Rocephin, ceftriaxone, started insulin infusion for what was thought could be DKA. Re-examination of the abdomen, distended, exquisitely tender with rebound and guarding. Family arrived shortly thereafter and said the patient had been anorexic for the last 5 days of upper abdominal pain, which is similar to that first visit, which was 4 days previous, vomiting constantly, and a gradual worsening mental status. But unfortunately, on recheck of the vital signs, the patient is now hypotensive. And I think, Colin, this was the blood pressure you were referring to. So blood cultures are ordered, as well as the lactate level, and a CT abdomen pelvis with IV contrast. So, George, just keeping you at the microphone here, George. CT scan. Would IV contrast? I want to get real nuts and bolts, like bedside on this, but IV contrast, you call to the text, they take the patient over right away, or you think we have a few minutes of time, or do you do it non-con just because you don't even want to hassle with the whole put in quotes contrast nephropathy thing? Where are you going specifically at this point, now that the patient is hypotensive?
So that's actually more worrisome, and we all are trying to avoid that CT scan code blue that occurs. And so this patient is probably a little sick to go to the CT scanner at this point in time, and I would continue resuscitating this patient. He's hypotensive, he's tachycardic. Clearly he has something intra-abdominal that's causing his discomfort, and he's exquisitely tender. And so I'm really worried about an abdominal catastrophe. Certainly in that differential is going to include thinking about AAA again, trying to figure out exactly, again, what could be potentially causing this person's acidosis, what could be causing this person's hypotension. And if you see a patient with hypotension with abdominal pain, AAA has to be towards the front of your diagnosis. Again, you're also thinking about the fact that this patient's elderly, mesenteric ischemia, intra-abdominal sepsis, all of those things can be potentially going on. And so first thing is going to be to resuscitate this patient as much as possible, continuing to give this patient fluids, maybe even starting this patient on vasopressors to get them stable enough to go to the CT scanner. In this circumstance, this patient's critically ill, and one of my favorite memes that I like to put on is a picture of Batman smacking Robin and saying, I'm not going to say the word, but F-bomb the creatinine. And that's what I would be telling the CT tech. F-bomb the creatinine.
Right.
I don't really care about the creatinine in this circumstance, because again, if we're going to see a AAA, we want to see it with contrast. If we don't want to miss a potential diagnosis in this patient population, certainly. So I would not wait on the creatinine to come down with IV fluids. This person would be getting, especially in the setting of the fact that the patient had a normal creatinine during his previous visit 4 days ago. I know this person's very likely to be volume down, probably has an element of AKI secondary to hypovolemia. This patient's probably going to have a return of his baseline creatinine once he is adequately resuscitated. So I'm going to go straight to CT scanner and get this with contrast to figure out what the etiology is going on for this patient's abdominal pain.
Awesome. And certainly, I mean, you mentioned AAA, right? So if there was a delay getting a CT scan, certainly doing an ultrasound at the bedside would be
Absolutely.
an easy thing while you're resuscitating that patient. So why don't we do this? We could ask about the patient's blood pressure, and then the next step, because now the patient has received a fair amount of fluid. So why don't we ask Nicole, and then Mike Pallaci, and then Jennifer Hicks, if you guys want to, just like sort of in turn like that. Nicole, can you just give us a couple sort of pro tips on blood pressure and maybe some next steps, and then we'll ask also Mike and also Jennifer about that.
So when the patient initially came in for this bounce back visit, their blood pressure was 135/76, and now suddenly the blood pressure is 86/57. So something has dramatically changed even within this bounce back visit. That is concerning to me, especially since the patient has already received 2 liters of normal saline. So they're pretty tanked up on crystalloids, and yet still the blood pressure is dropping. So a few things run through my mind. I mean, everyone knows that the initial blood pressure is always slightly elevated, but I don't think that in this case we're dealing with, just an initial white coat syndrome with this patient. So with such a drop in blood pressure in someone who is in theory well resuscitated on crystalloids, you have to start thinking about the fact that this patient is going into shock. And when we're thinking about shock, there's the 4 different types of shock, whether they're in hypovolemic shock, if they're in distributive, obstructive, or cardiogenic. So you have these 4 types of shock. How are you going to differentiate between them? So I think at this point, my major action item, and this was alluded to in the past, but I would reach for my bedside POCUS and do a rush exam. I want to see the pump. I want to see the tank. I want to see the pipes. I want to try to figure out exactly where the origin of this shock is coming from. And leading with the idea that there's badness in this patient's belly, probably this is some form of vasoplegic distributive shock. I think that this is probably septic shock, but it hasn't been excluded yet. We don't know. I mean, it is still possible that it's hypovolemic shock, although they've received lots of fluids. Could it be this AAA that we've been talking about? Could it be a GI bleed? The rectal exam still hasn't been commented on. So these are all other reasons why the patient might be hypovolemic and may benefit from more volume or blood. And then finally, as you guys probably have noted, the tachycardia keeps creeping up. So at some point, have we missed the opportunity to repeat an EKG? Is this some kind of a cardiogenic shock where now that the patient is getting more and more septic, are they in a tachyarrhythmia that is not sustaining their physiology? Are they in AFib with RVR? Is this some myocardial stunning? So I think at this point, my 2 action items would be a rush exam as well as a rectal exam. That would be my next 2 steps.
Awesome. Mike Pallaci, why don't you give us like a maybe 30, 45 second type of insights, and then Jennifer will ask you for the same thing.
Well, I don't know if I have 30 or 45 seconds left after Nicole. That was really my thoughts. I want to see what the ultrasound looks like. And yeah, I agree with the rectal exam as well, but the ultrasound is really going to give us a lot of information here. I want to see if we've filled the tank at all with those with the fluids that we've given. I have gone my practice on this has really changed in the 60 or 70 years that I've been, no, that's not true. Like the 23 years or so that I've been practicing, in that I am much more aggressive going for pressors earlier now, even if it's just push dose, to give them a little support while I do some volume resuscitation, or just as a bridge until I can get a drip at the bedside. But I think this patient is probably more than 2 liters down in terms of volume, probably could afford some more, but I don't want to just guess that. I want to take a look and see if we're getting and see what the rush exam looks like. So I'm completely on board with Nicole on that.
Okay, Jennifer, give us some thoughts.
I would agree with what they were saying as well, and maybe even just considering getting your surgical friends on board here if you think that there is a bleed significant enough to cause this amount of hypotension despite the resuscitation that's already been done as well.
Yeah, I mean, and when you think about it, just like you're saying, I mean, if you had, I mean, sometimes you don't even need to use a finger. You just look and there's like a whole bunch of blood in the adult diapers, right? And sometimes that can, just that part of the physical exam, not commonly, but when you do see that, that certainly can be helpful. Um, let's move forward a little bit just so we don't run out of time because I want to make sure we all have some time for take-home points here too. And so I'm going to ask Steve and also Colin in just half a second here. So what happens? We get a CT scan, and that's done at 8:07. Free fluid of the pelvis, inflammation around the stomach, suggestive of gastritis or duodenitis. Thank you very much. That's very helpful. No peripheral obstruction, no liver, spleen, kidney, small, large bowel, gallbladder is absent. And they have an impression, likely gastritis. So, wow, interesting. No AAA, and then not really a greatly helpful CT scan. So before we talk about the fact that now the blood pressures continue to drop, the heart rate's continuing to go up, Colin Kaide, what do you think? Like, we thought we'd get our answer here. We didn't. I mean, this is disappointing.
Well, I have to say, unless your CAT scanner is in the middle of nowhere or the bottom basement or the other side of the universe, I would have to channel Arnold Schwarzenegger and say, there is no creatinine. Get to the scanner now. You need to see the angiogram so I can figure out where you're bleeding from. So I might say I really want to get a little bit more information, and I might have added a CTA up front. But now that I see that there's potential for um, a, 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 another problem here, maybe this patient has got a arterial obstruction. Maybe this is just a GI bleed, and it hasn't caught up to me yet. I'm probably going to go back and I'm going to say maybe I want a little more information, because nobody that I call will do anything unless I have a decent amount of information.
Yeah, and it's interesting. I mean, understanding the limitations of the test that you're doing. So if you do a non-con scan, you're not going to see obstruction. I remember there was a case, this is back at Mount Carmel St. Anne's, but it was a hospitalist, and they were really reluctant to use creatinine because they were concerned about contrast nephropathy. And the patient had a aortic occlusion. It wasn't a triple aortic dissection, but they basically had a clot in their aorta, and the patient ended up dying. And it was because they did a test that didn't have adequate sensitivity. Not that they should have been looking specifically for that diagnosis, but just like what you're saying, right? You know, a GI protocol CT scan or an angiogram looking for some type of obstruction or mesenteric ischemia or an SMA clot. I mean, all those are things that contrast would be helpful with. And, you know, look, most of the time non-con scans are really good. So let's ask the person who was actually there in the room, like the musical Hamilton, right? Steve, do you remember when this CAT scan came back? I mean, were you disappointed? And did you know about the GI bleed at that time, or was it later when it was found out that he had this big maroon colored stool?
Yeah, the GI bleed did not manifest until later. And yes, I was absolutely disappointed by the CT scan findings. I was feeling very, very unsettled with this case really from the beginning, but especially after the CT scan came back. I remember feeling really, I mean, the reason I wrote about this case for this book is because of how much the case stressed me out. And in real time, this was very stressful because I knew it was all wrong. But I didn't have a better idea in the moment. So we just continued on with this.
Okay. All right. So we have 10 minutes left, and I will pledge that we will be done exactly at 9 o'clock here. And I will also pledge that there will be no discussions of politics tonight either. And we've been pretty good for the first 50 minutes of that. So I hesitate to have even mentioned it. So Jennifer Hicks, if you could just very briefly give us a couple of etiologies of GI bleed, and then we'll move on to Mike talking about if the patient would have had a perf viscous, how that might appear on CT, and comparing that to a acute abdominal series. So Jennifer, a couple things on the differential of GI bleed.
Yeah, so some things that can cause like an upper GI bleed, you're thinking of an ulcer, esophagitis, esophageal varices, like a Mallory Weiss tear. Some things for lower GI bleeds, you could think about like inflammatory bowel disease, hemorrhoids, diverticular disease, polyps, anal fissures, ischemic or infectious colitis, angiodysplasia, and then cancer can really cause a GI bleed anywhere in the GI tract.
Yeah, I mean, not that this patient would have necessarily been able to tell you this at the first visit, but unintentional weight loss is a question I have tried to incorporate more and more into my histories for a whole range of things. And again, not commonly helpful, but when it is helpful, or when that is found, sometimes that can actually change management. So, Mike Pallaci, perforated viscous and CT scan, how does that appear? Like, what are we going to see on CT with the perf viscous?
The classic thing we're looking for is free intraluminal air, right? And if we did use oral contrast, which we would never do in this study, obviously, for someone that's unstable, we need an answer more quickly. But if you did give oral contrast, you might see an oral contrast leak. Sometimes you can also see discontinuity of the bowel wall, but there's other things. It doesn't always cause pneumoperitoneum. You can have a bowel perf without actually free air being seen in the abdomen. Looking for things like a phlegmon or an abscess at the perforation site that is maybe blocking the flow of air out of the bowel and into the peritoneum is something to consider. So that is something that you need to keep in mind as well, that the absence of free air on CT doesn't completely exclude the possibility of a perforated viscous, although it does make it significantly less likely.
And we don't have much time. I'm going to tell the story real quickly. Mike put something in the chat, has not ordered acute abdominal series for 20 years. Mike, I also had that record of 20 years no acute abdominal series until a patient had a GI procedure. They had some polyps that were snared, walked to the parking lot, severe pain, came back in, and the GI doctor called and said, "Hey, can you get acute abdominal series?" And I'm like, "Oh, really?" So anyways, I had them come in the room, got it. I looked at it, it was normal, and then sent them for the test. I wanted to do the CT, showed that they did have a perf. So I do not have my streak any longer. And I'm now starting again. I'm at 1 year. I'm 19 more to go, and I'll be able to beat your streak, Mike. Okay. So at any rate, Nicole, I have a long question for you, but only about 60 seconds to have you answer it here. How should you manage a GI bleed, including resuscitation, pharmacotherapy, and transfusion? Because as Jennifer told us, could be anything from esophageal varices, bleeding very quickly, down to something like a malignancy that's a lower GI bleed.
Since I only have 60 seconds, I'm gonna dumb it down a little bit. So I'm gonna go into like resuscitation mode. So the first thing I'm gonna check is, do I have adequate access? So far, we've been treating DKA and sepsis. Presumably, maybe I have a central line, but as we all know, a central line, a triple lumen central line, does not give you the same resuscitation as 2 large bore IVs or a single lumen central catheter. So access would be key. We've already given this patient tons of crystalloids, so I would stop diluting their blood anymore and then switch to blood products. Whatever the massive transfusion protocol is at your institution, every institution has its own flavor of this, but the idea would be to get them their tank filled, but with blood products. And then I would start thinking about anything that I can reverse. A lot of our patients these days are on DOACs or on warfarin, so reaching for the prothrombin complex concentrate. And then probably maybe like my 4th brain cell would go to other things like PPI drip, octreotide if this patient is in any way a liver patient. But I think the big thing is access, fill the tank, blood products, reverse anything that's worth reversing, and then get on the phone with whoever I need for definitive management.
Excellent. So Colin, our very last question before we get closing thoughts for everyone and the QR code for the CME. Who do you call first? GI, IR, surgery?
Well, I think, first of all, there's a little bit of institutional dependence here. Depending what you have and what you have available. Knowing the entire story, knowing what I know now, I'm probably going to call gastro first, because they're going to be the people who are probably going to lead this, this potential for cauterization or whatever. If I had a CTA, I might consider interventional radiology, but as I always tell my residents, IR is interventional radiology, but IR is also the Spanish verb ir, to go. So at 5 o'clock, they go away and go home, and they don't like to come back. They like to ir very much. So I'm going to have a little problem maybe getting them back in a timely fashion. And this is true even in a tertiary referral center like OSU. So I might try to get gastro involved first, but I'm certainly going to, at least if I have a CTA result, light up IR. If I really don't have them, some institutions, surgery will do the scopes and do some intervention. So it kind of depends on what I see and what I know when I'm going to make the call.
Awesome. All right. So what happens? Reread of the CT scan, interestingly, does show free air around the stomach and duodenum. And there was actually a comment about sitting the patient up and being able to find free air in the chat there. Surgery is consulted, repairs a large duodenal ulcer in the OR, and the patient is discharged 2 weeks later. And he now can play the piano. No, just kidding. But anyways, he's returned to his baseline mental status. So let's do this. We've got 4 minutes to go. I say, like 20, 30 seconds, one quick teaching point from each of us. Jennifer, will you go first?
Sure. So, abdominal pain, just remembering that is a really challenging complaint in the ED, and it could be something completely benign, and most of the time it is, but it can also be very life-threatening. So just keeping that differential broad and really relying on your history and physical to kind of guide your workup and doing that repeat physical exam prior to getting them out of the ED.
Love it. Mike Pallaci, one closing thought.
I think it's probably that the lack of free air on CT does not completely exclude the lack of perforation, and that I'm stealing Colin Kaide's medical dad joke for IR.
Colin Kaide, you're next.
I would say the number one thing is be careful if things don't add up and you're going along in your workup and you find something that didn't make sense to you, go back and re-examine and make sure you're on the correct pathway for diagnosis. I'll give one other little minor point. Be careful when you decide on your consultants. Don't be a serial killer and spend hours and hours and hours serially consulting different people. Get everybody involved that you think might be necessary and be a parallel killer.
Steve Kornweiss.
Well, Colin took mine with the thought process around diagnosis, but the secondary point here, this case made me read all of my own imaging in any patient where I had any legitimate concern, because after this I went back and I was very easily able to see the free air myself. And had I pulled up that CT, I was a very, very junior attending. Had I pulled up that CT scan on my own and had the confidence to review my own imaging on this case, that would have, it's not reflected in the slide here, but there was a large time gap between that initial read and when the free air was finally actually found and the patient got surgery. That happened quite a bit later in the patient's hospital course. And I could have saved that patient a lot of further deterioration down the line had I read that imaging myself.
Wow, George.
It is got to be about DKA, and that is not all that is hyperglycemia and acidosis is DKA. It is incumbent upon the clinician to look for other potential causes. Unless a patient comes in telling you, I have not been taking my insulin and therefore I feel like I'm in DKA, look for other etiologies and start getting those other labs, looking at toxic alcohols, looking at aspirin, looking at all of the things in mud piles to make sure you're not missing another potential cause of an anti-gap acidosis.
Well, thank you so much to our panel for taking the time and the prep to do this. Thank you to all of our participants. This will be posted tomorrow on the EM Bouncebacks website. So if folks want to see it, or if you have other folks or residents that you think would benefit from watching it, certainly feel free. That's, of course, all free. Anyone could get on there and do that. And for folks who'd like to join us for our next book club, and I'll put the QR code for the CME back in just half a second here. Here's the QR code for December 2nd, a 29-year-old man with quadriplegia and a fever, an equally easy case such as just like this one was. So anyway, it's an hour of the time. Hopefully we have been true to everyone for that. This is the code for the CME credit, and we'll look forward to talking to folks next month. Thank you all again so much for joining us tonight and sharing this hour with us. All right, guys, thanks again. Really great job.
Mike, thanks for the opportunity.
Take care, everybody.
Nice seeing everybody.